not sure. There's a couple of numbers on there. I don't see any names.
Agreed. I'm looking as well to help us here, make sure we have a quorum. There is Lindy.
Well, I think that's the three
Yeah.
that we need. Okay.
Oh, there you go.
All right. So I'm calling this regular meeting of the Boulder County Board of Health to order at 5:32 on Monday, October 11th, 2021. Can I ask the board members attending to introduce themselves? I'm Greg Thomas, board president.
This is Brooke Harrison, board member.
This is Lindy Hinman, board member.
And I know we won't have Landry tonight, and Morgan.
This is Morgan McMillan, board member.
Okay, thanks, Morgan.
Great.
All right. So we do have a quorum, and this regular meeting of the Board of Health has been called to order. Discretion of Public Health Executive Director Camille Rodriguez. Notice of this meeting was posted on the Board of Health's website and included the phone numbers, conference ID, and public comment link and instructions. So with that, we will go to the agenda. And that is, okay, so first up on the agenda is public comments. I'm guessing we do have a few commenters. We also have some written comments. I'm opening those up. So let's see, who was helping lead this in the prior meetings in terms of the order?
I know that President Thomas, this is Executive Director Rodriguez, and I know that last time we had either Rita or Kate Haywood assist us with the order in which people registered for comment. And I do believe that we have I think it's at the pleasure of the board if written comments were submitted, if they are read or rather entered into the public record and document following this meeting. Am I incorrect, Ms. Haywood, in my description therein of the process?
No, thank you, Director Rodriguez. That is correct. And President Thomas, if it works for the board, I'm happy to read down the list of individuals that have submitted written comment and or wish to speak. So we will start with Justin Verant. Mr. Verant, are you on? Okay, he just provided a written comment. Carolyn Beninsky.
Yes, I'm here. Yes, I'm here.
Great, thank you. We are in receipt of your written comment. Would you like to make any statements to the board right now? You'll have up to 3 minutes.
Yes, I would.
Okay, great. Could you just please state your address for the record?
3335 16th Street, Boulder, Colorado.
Perfect, thank you. You can go ahead.
Okay, so basically I'm going to go through my comment that I sent you in case you didn't get a chance to look at it. My name's Carolyn Beninsky. I've lived in Boulder County for 35 years, and I urge you to oppose and take all possible legal actions to ban COVID vaccine mandates for members of our community, including school personnel and students of all ages. So I'm talking about mandates, vaccine mandates here. U.S. federal law prohibits mandating all currently available COVID vaccines because they are available only under emergency use. While the COVID vaccine was recently approved by the FDA, it has not been produced and won't be available for at least another year or two. If a person goes to get a COVID injection at the present time, it will be the experimental shot and not the fully approved one. An even more compelling argument against mandates, however, are the provisions of the Nuremberg Code, adopted after the Nazi experiments, medical experiments during World War II. I sent you a link to the code, and this is what the code said. The voluntary consent of the human subject is absolutely essential. This means that the person involved shall have legal capacity to give consent, shall be situated so as to be able to exercise free power of choice without the intervention of any element of force, fraud, deceit, duress, and finally, particularly coercion of any kind. So I'm not going to read the whole thing, but you can read the whole Nuremberg Code. I've given you the link. The U.S. is a signatory to this extremely important response to human atrocities, and it applies to all officials and volunteers in a position to make decisions about other people. Although we were seeing universities and governors and the President of the United States mandating these vaccines, it is illegal, and they can be held accountable under U.S. law and the Nuremberg Code. I want to say something about children, so I urge you to adamantly reject any and all COVID vaccine mandates for anyone in our community, including staff, teachers, and students in the schools. Finally, I want to just say that children, almost 100% of children don't suffer from severe COVID. There's very few deaths from it. A lot of children don't even have symptoms. And the World Health Organization has said that young people should not take the vaccine. There's a concerning number of young people, especially under 30, who are getting myocarditis, blood clots, low platelets, and more
Your time's
following
up.
these
Thank you.
vaccines.
Thank you for your comment, ma'am. Darielle Blackburn. Darielle Blackburn, are you on the call? Okay, we will move on. Mr. Mark Leslie.
Yes, I'm here. I'd like to talk about, let's follow a little bit of money that BOH and BCPH has been receiving through this COVID.
And I apologize, Mr. Leslie, before you begin, can you just state your address?
Well, because of ongoing harassment due to other things going on in Boulder County, I'll give you my zip code. I've already submitted my address.
Oh, okay.
You have that.
Okay.
And my zip code is 80301.
Okay, great. Thank you. You can begin.
Mm-hmm. All right. So looks like the CDC in their 2021 ELC-based funding and COVID-19 funding incentivized, public health agencies across 50 states with hundreds of millions of dollars. Colorado has received over $6 million in ELC-based funding, $683 million in COVID-19 funding for the 64 counties. So I did a core request about BCPH, and they alone received over $5,794,000 million in COVID-19 budget. That was per the COVID-19 budget instructions, budget table, and narrative sheet. And that also indicates over $1.9 million was spent on contractual support for the scope of work to hire investigators and epidemiologists. That seems like quite the financial incentive for those people to follow this narrative. So out of curiosity, I submitted a core request to understand what information, documentation, and investigation practices BOH and BCPH was utilizing to make independent evaluations of the science to formulate the best and safest policies for the people of Boulder County. To my dismay, my core request returned only CDC guidelines is the sole authoritative source for those decisions being made. I've got quite a few references of those sources based on that core request. But if BOH and BCPH is just going to be the mouthpiece for the CDC, why do we need you guys? There's no point. you have an obligation and duty to the citizens to be independent thinkers and put Boulder County residents first. BOH was entrusted with serving the public good and to have high standards in morals, ethics, and to adhere to valid scientific methodologies. However, you've repeatedly ignored doctors, nurses, industrial hygienists, and other frontline workers treating thousands of COVID patients with real science and real facts, and instead relied on guidance from a private organization like the CDC, headed by a political employee, and accepted financial incentives to implement policies, practices, and mandates based on biased studies, misleading and false information that were utilized to create unconstitutional mandates. And mandates are not laws. You need to go look that up. COVID's a lie. The pathogen has not been identified, and I put forth to you to submit the material evidence to the people of Boulder County of the existence of the pathogen, thereby proving the policies and practices you're implementing and the mandates are justified. If not, we'll take it to court. You know, you could also earn 3 million euros in the EU if you do prove it. That's pretty interesting. All right, thank you for your time, and we'll be watching. Enough is enough.
Great, thank you. Cynthia Nevison, are you on the call? Cynthia Nevison? Okay, we'll move on. Lori Hansen, are you on the call?
Yes, I am.
Great, thank you. We've received your written comment. Would you like to speak as well?
Oh, okay. Yes, please.
Okay, great. You have 3 minutes. And a clarification for the group, we do have everyone's addresses, so I won't need to ask that going forward. So Lori, you have 3 minutes that begin now.
Okay. I just want to talk about the mask mandate. I think you guys do a great job. But the mask mandate, I guess I'm just hoping that you're not just concentrating on case counts. I have a feeling that might be happening because I saw something from the city council saying that the majority of people getting it now were kids 11 and younger. And the city council asked them if there were many hospitalizations, and they said no, not at all. So it makes me think that you guys are just concentrating on getting the number down to 50 cases per 100,000 people. But that just tells part of the story. Now, from the very beginning, it seemed from the CDC and Governor Polis that the hospitalization rate was the most important thing to look at. So I'm hoping you guys can tell, I know you can't talk to me, but I'm hoping you can tell me I'm wrong, that is case counts isn't the only thing that you're looking at. But it seems like our hospitalization rates aren't bad. And from the latest data I looked at on the ICU beds, it looked that we didn't have a shortage of ICU beds. So that's what, on the Washington Post the other day, it said, until we stop fixating just on case counts, we're never going to recover. I guess I kind of agree. And you might say that, well, what's the harm in having a mask mandate? There's nothing negative that can come out of it. But boy, a lot of people I talk to, it really is hurting the businesses, because a lot of people I talk to are taking their business elsewhere. A friend of mine does her grocery shopping in Firestone. Another one goes to Target and Kohl's at Orchards. Another one goes to eat at Centera and Broomfield, because they, the rest of the counties around us don't agree with what you guys are doing. So you guys are hurting the very businesses that you said you wanted to protect from all of this. And then you say, well, some people are coming here because they like the mask mandate. Well, those friends of mine who like the mask mandate, they're staying home because they're saying, well, if there's a mask mandate, it means that things are really bad again. And I told my husband, Mike, we're not going out to any restaurants. We're not going to any stores. I'm going to order online because it means things are really bad. So whether you agree with it or not, if there's a mask mandate, it either keeps people home or makes people angry, and they're going to nearby counties. So our businesses are really being affected by this, and that's a shame. And someone on the hotline told me, I think I'm running out of time. That it's because we have a transient population, but Denver does too, and they don't have a mask mandate. So I really
Your time is up. Thank you.
Thank you.
Great. Thank you for your comment. Aaron Meshke, are you on the call? Aaron Meshke? Okay. Heather Muller? Heather Muller? Okay. Sam Gates.
Yeah, I'm here.
Great. Thank
Can you hear
you.
me?
Would you like to make a comment?
I would.
Okay, great. You can go ahead. Your 3 minutes will start now.
Thank you. All right, so I hope everyone listening is having a good night. I'm calling in strong opposition to BCPH's current mask mandate and to your actions during the last year more generally. I don't think I've ever seen a public agency less in tune with the decisions and preferences of its constituents. For background, I'm a student at CU Boulder, and I just want to say that from our perspective, any respect, trust, or support that this agency had from probably 90+% of the student population has been lost over the last year, especially after the orders 2020, 07, 08, and 09, all of which were completely discriminatory and futile from our view. And only one member of this board is an actual medical doctor, and I know that the executive director holds a bachelor's degree in anthropology. Now, of course, there's nothing wrong with that, but the point is most of you are not necessarily experts in infectious disease or public health to the extent that you should be making these policies based on your own discretion, like a previous caller stated. So at best, a lot of you are just administrators. And this county is one of the only 4 in the state with a current mask mandate, despite our high vax rate. And many citizens are either non-compliant or only comply with it to a bare minimum. They're over it. So while this board holds performative talks with city council regarding whether or not they should even return to their chambers to serve the public, the rest of us have been delivering your food and staffing businesses as we always have. It's clear that this board needs a reality check. I'd say the most egregious thing is the minimum age of 2 for masking. Less than 500 children have died nationwide from COVID. They're at almost zero risk. And there's obviously clear downsides to their development, sense of normalcy, and communication. And as another caller said as well, the WHO and most European countries recommend against masking children under 5 for these very reasons. And many countries don't mask them under 12. So what's the justification? What does BCPH know that these other bodies don't know? Do we suppose that you guys conducted some research to justify this stricter stance, or do you have more expertise than the WHO? Probably not. So I'm sure that you'll probably attribute the recent fall in cases to your mandate, despite the fact that they're plummeting across the country. But there's no statistically significant difference across jurisdictions based on these mask mandates. And like another caller said, there's other counties that don't have them that are taking our business and doing just fine. So I suppose by this point in the game, these criticisms probably roll off all of you like water, which I have to understand. But regardless, I think that your policies have caused untold harm to this community for little gain. And I think you've harmed small business, driven mental health problems among the community and students, alienated the university community, and forced illogical mandates for dubious benefit. So I think the best thing for this community would be your immediate resignations, and I yield the rest of my time. Thank you.
Great. Thank you for your comment. Cynthia Nevison? Cynthia Nevison? Okay, and Andrew Alexander. And I see that you are here. And so your 3 minutes will start now. Oh, we can't hear you.
All right, you can hear me now, right?
We can, thank you.
Yeah, I also think the mask mandates are anti-science and irrational, and I'll read some of my statement. To go back to a previous caller, if you look at the stats in Boulder County, we've had 250 deaths and I think 850 hospitalizations. And yet, if you look at the Boulder County, the way that we decide whether a mask mandate is in place is we refer to CDC guidance on transmission rates, which is basically crazy. And I'll just read some of my statement. The problem with the recent public health order regarding masking is you are basically abdicating your decision-making to the CDC. In abdicating to the CDC, you are outsourcing your decision-making regarding COVID. Therefore, let's review the CDC guidance. So if you look at the CDC guidance on what constitutes substantial transmission, it's new cases per 100,000 people in the last 7 days, and then % of positive tests during the past 7 days. Now, the key point here is that the CDC hasn't changed their recommendations on community transmission, even though vaccinations have been like very prevalent in the last 6 months. So for some reason, we're still stuck in this case rate data, which makes no sense. And to make it even crazier, as of September 26, 2021, 95% of the counties in the United States are in high transmission status, according to the CDC. So I sent this written statement in. I'll kind of, so the definition of high transmission seems arbitrary. I have yet to see what it is based on. According to my reading, our community could be in substantial transmission if only 10 people got tested in 7 days and 1 tested positive, right? So this is somewhat farcical. And again, those guidelines have not been updated to reflect the efficacy of the vaccine. Now let's switch. So, I mean, masking adults as they go shopping, and, you know, basically most people ignore the mask mandates unless a worker tells them to put it on. I guess that's like fine. It's totally useless, but it's fine. But the thing is that you guys are also supporting the masking of children. Children are simply not susceptible to COVID. Masks are now not mandatory in classrooms in the UK, Iceland, Denmark, Sweden, Finland, Norway, Switzerland, Austria, Netherlands, Belgium, 12 and under, Russia, Poland, Hungary, Bulgaria, most of South America. Masking children in the US isn't science. Also, remember, the WHO does not recommend masking kids 0 to 5 years old in any circumstance. And then the WHO says masking of kids 6 to 11 should follow considerations that are basically impossible to mandate mask wearing on an entire school and still take those factors into account appropriately. Boulder County Public Health has an opportunity to be independent thinkers on this. If they continue to outsource all thinking to the CDC, which has lost the trust of the public, people will lose trust.
Your time is up. Thank you.
Thank you. And that concludes all of the public comment.
Hey, Kate, I think we skipped number 9, Matt Gottschall.
Oh, apologies, Matt Gottschall?
Yes, I'm here. Can you hear me?
Yeah, sorry about that. You can go ahead.
Sure. First of all, thank you for allowing me to speak. I'm a 34-year-old father of 3. I live and work inside the city of Boulder and attended the Leeds School of Business for undergraduate and graduate school. And I've loved Boulder ever since I first moved here in 2005. I feel like it's one of the best places to live in the country and appreciate how our public policies have made it that way. The arrival of COVID-19 was as scary as any unknown deadly respiratory virus could be. Many people died and we mourned them all. But as time went on, we learned how it's transmitted, who's at risk, and we've developed a vaccine. It's been a great effort with lots to celebrate. I've been sending my 4-year-old daughter to preschool. A few weeks ago, she looked at me forlorn and helpless and said, "Daddy, everyone keeps telling me not to get other people sick." She sounded defeated, and the county had recently started requiring masks at her school, and several false positive COVID tests have sent her class into temporary quarantine. She seemed unable to understand how not to get people sick when she herself is not sick. What a terrible reality. Rather than exploring her world and playing make-believe with her friends, she's now being told that she and her friends are deadly contagions that could kill their grandparents, friends, or in our case, our newborn baby, with something totally outside her power or awareness. How terrifying. My heart's broken for her. Plenty of people argue, well, that's exactly right. That is what could happen. But my experience is that this fear is hurting our kids. Simply put, requiring the teachers put a mask on my very young children is hurting them. Their mental health is not just at risk. You are actively damaging it. If there's one thing we're sure of, it's that children are not contracting or spreading this virus in large numbers. Yeah, it's circulating in schools, but it isn't putting kids in hospitals or ICUs. They just aren't a serious risk. I can appreciate that you're trying to follow CDC guidance, but they are being overly risk averse. As far as I can tell, Boulder is the only county in Colorado masking kids as young as 2. Other communities aren't willing to do that to their kids. So why are you? It used to be scary to think that kids could get COVID at school and bring it home to adults, but now we can all be vaccinated. The virus is here and it's going to pass around forever. Zero COVID is not possible. I'd be happy to hear of alternate school accommodations for high-risk children or those who have high-risk members of their household, but for the vast majority of this has gone on too far and too long. So I request that you cancel the mask policy for kids. We're ready to live with this virus. Take the masks off our kids, please. I want to see their beautiful smiling faces again, even if they sneeze in mine from time to time. Any parent will tell you it's worth it.
Great, thank you. And that concludes the public comment portion of the meeting.
Okay. All right, let's see here. We are moving on to agenda 2. Item 2, approval of September 13th, 2021 regular meeting minutes.
This is Morgan. I move to approve the meeting minutes.
This is Brooke. I second.
Okay, all in favor? Aye.
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 All right, on to item 3, a tribute to Boulder County Public Health Chief Medical Officer, Dr. Christopher Urbina, MD. And introducing the new BCPH Chief Medical Officer, Dr. Michelle Haas.
I can take that from here, President Thomas, if you don't mind. Okay, thank you. Just as President Thomas led you to what I'm about to speak of, I do want to give an intro to our new Chief Medical Officer, Dr. Michelle Haas. But first, I do want to talk about Chris Urbina. He always, in the short bit of time that I've gotten to know him, said, "Don't call me doctor, Camille, don't do it. I'm a person too." And that's okay. But this one time, Dr. Urbina, I'm going to go against you and say, I have so many wonderful things to share that staff have put together to say about your, I think it's 6 years with us. You know, normally, and I've worked with a lot of chief medical officers in my past, they advise and educate. They provide recommendations on clinical decisions that public health staff have to make. And Chris did all of those things. But above and beyond that, you know, he had the credentials to lead a health department. He has an MD and an MPH. He's an equity champion. He retired from state health as their executive director and came to us. So how lucky could we be that he knew how to navigate state level challenges and decision making at the local level. He continued to work with those in the Denver community most in need by volunteering as a doc at Clinica Tepayek. And he allowed us to borrow those incredible skills for over 6 years. He knew how to navigate the relationships at the state level and local level. He's really good and always has been at navigating difficult decisions in stressful times, and the pandemic is one of those. He really is amazing at building strong relationships. He has a great sense of humor too, and keeps us all smiling while we're in these stressful times. He addresses those tough issues head on. He has strong respect and rapport with staff and partners alike. He is always available. In my short tenure with this department, I met with him at 6 o'clock in the morning one time because it was just important and because we had other work to do, and that was when we could meet. And I'm sure others could tell similar stories. He was always at any meeting that we asked him to be, and served many more local health departments than just us at one time. He's an excellent presenter. He can handle any question or situation when it comes up. And he's been a mentor and a coach to so many of us at Boulder County Public Health. And I think that's what's really special. You never really felt like you were sitting with a doctor, although you knew you were. And that's perhaps why he always said to me, "I'm just a person, Camille, don't call me doctor." So Chris, I didn't get to work with you enough, but I know we will stay connected, and I know that you'll always be a listening ear for us when we need you, and I see your thumbs up. Before you get a chance to speak, Chris, because I know you might have a few words to say, President Thomas, I do want you to offer up a moment to any of the Board of Health members that want to say a few words, because all of the comments that I provided were from some of our staff who shared those for me to present to you, and some from my heart as well. So I'll turn it over to Board President Thomas, and then we'll go from there.
Thanks, Camille. Yeah, Dr. Urbina, Chris, I've known you for a long time. Your work with Denver Public Health and moving on to CDPHE, and I don't know how many of the last several years for Boulder County. You know, I got to say you know, someone who is kind of, you know, an observer of how you handle people all across different levels of organizations. I got to say, whether it was a serious conversation or whether it was just a jovial conversation, you always do it with a smile on your face in that trademark way. And I got to say, you know, there have been times when I've thought, like, what would Chris Urbina do in this situation? So again, thank you for all your years of service in public health and environment. And, you know, I wish you the best, and hopefully this is the fully jumping off point to your retirement. But you never know. You obviously like this work, so I wouldn't be surprised to see your name pop up again. But I, for one, appreciate your service throughout the years. So thank you very much.
Thank you, Board of Health. Chris, do you have a few words you'd like to share with us?
You know, I'm likely to get emotional, so I just want to say thank you to all of you. The leadership of the Board of Health, the current leadership, Lexi, Camille, you've been tremendous, and it's been really a gift to work with all of you. And despite the public comment, I've been a doctor for over 40 years, and I make sound decisions and recommendations based on the science. And I think Boulder has done a tremendous job of leading the way. We may have differences of opinion, and I respect the differences of opinion. I try to treat people with respect, and I think our staff have tried to treat people with respect. So it's been a real gift. I can't thank you enough for the opportunity to work with all of you, and I will cherish our friendships forever. Thank you, Camille, Lexi, Board of Health, and thank you, community. You know, these are difficult times, you know, and no one really wants to suffer, and I feel your pain. My dad suffered with COVID, nearly died. We didn't see him for over a year. We had lots of friends that have died from COVID, and so I respect and I appreciate your opinions. I have opinions, but I think Boulder County is doing the right direction and leading the effort. So thank you all.
Thank you, Chris. I really appreciate you saying a few words because I know you wanted to waltz off, or actually ride your bike off into the sunset. So we'll try not to call on you too much, although we might sometimes because you said we can. But one of the reasons that we're in good hands is that you've done a great amount of work with Dr. Michelle Haas to onboard her to our Boulder County Public Health Department. Dr. Haas, I know I put a sort of a bio in our Board of Health packet that I'm not going to read to the Board of Health or to our public and staff. But welcome, Dr. Haas. I'm so glad that you got to spend some time with Dr. Urbina, and I know that you can ask a question any time of him. But say a few words to us. We're getting to know you, Board of Health and staff. You should know that Dr. Haas has been joining us in meetings and getting to know all of our decision-making points and issues that we are bringing now to her instead of to Chris. And so welcome, Dr. Haas, to Boulder County Public Health. Please say a couple words.
Well, thank you so much for that warm welcome. So just so everyone knows, I'm Michelle Huss. I'm an infectious diseases physician, and I'm primarily based at Denver Health within the Denver Metro TB program. And I've been an infectious diseases physician for 12 years and have worked in resource limited settings in Botswana and also worked here locally. I'm excited to join the team, and it's a real honor to transition into this role after Dr. Urbina has been in this role for such a long time, and I look forward to supporting the health of Boulder County. And I also really appreciated the comments from community members. I appreciate your thoughts. Thank you.
Thank you. That concludes this portion of the agenda. President Thomas, unless you had any other words to add. Thank you.
No, I look forward to working with you, Dr. Haas, and I've got 2 years left on my term, and yeah, I mean, we still got a little ways to go, it looks like. We can really use the assistance, so welcome aboard. Morgan.
Oh, I just wanted to jump in and share my thanks also with Dr. Urbina for all that you have done for our community and beyond these last several years. And we've really relied on your medical expertise and also your vision around equity. And Dr. Haas, I look forward to working with you and really admire the equity work that I have read about in your bio and look forward to you bringing that to our community as well. So thanks to you both.
All right, thank you very much. Okay, so agenda item 3. Agenda item 4. It's COVID-19 presentations. First one being situational update.
Thank you, President Thomas. I'm going to start this off because we have so many other staff that are going to present to you. And I know that I think it's Dr. Nolan that's going to put up a slide deck in a moment. I want to preview for you a few of the key messages that you are going to hear tonight. We do know that our surge of cases has slowed, but we are still in high transmission, and we are, as you know, inching in on flu season. And so we're hoping that you, as a board, have gotten your flu shot, and we're messaging that to the community. We have an uneven case distribution by geography, age, and ethnicity, and our staff will explain that to you. We were seeing a vaccination uptake, and it has slowed. Our hospitals are still under a strain. Regarding our public indoor masking public health order, we're working to ensure that our community understands the responsibilities and that we're supporting them in the ways that we can as a local public health department. Our vaccination verification program is proving popular, and our staff will explain that to you. And then our school masking public health order, you will get an update regarding, and we're going to show you that it is effectively reducing cases, outbreaks, and quarantines. So going forward, several staff have put in so much work into this presentation for you tonight, and so I will step away and Dr. Nolan will take it from here.
Thank you, Director Rodriguez. Good evening, Board of Health. Nice to be with you this evening. I'm only going to mention a couple of things. I'd like to review our goals just to recenter our thinking and what we're really trying to achieve with this work. Our first goal is really about preventing severe illness and death. We know that in Colorado, vaccinated folks are 3.3 times less likely to become a COVID case and 8.2 times less likely to be hospitalized for COVID, although we are seeing some breakthrough. We've had 17 deaths in Boulder County since May 1st, and we kind of peg that date as a date when a large proportion of the adult population at least had a chance to get vaccinated. We have had several deaths in September in Boulder County. There have been 645 child deaths from COVID in the United States, and in Boulder County, we've had 12 0 to 11-year-olds hospitalized in 2021. Our patients are tending to be younger and sicker in the hospital. And we know that about a third of cases seem to be having long-lasting effects. In relation to goal 2, being careful not to overwhelm the health system. Remember, it's a system, it's a collective response. Our hospitals and other health providers serve patients beyond Boulder County and serve needs beyond the COVID pandemic. So we have to be careful about how we are recognizing their needs and responding to them. The hospitalization rate in Colorado is still expected to peak in December, which means we have an upward trajectory still ahead of us. Non-emergency procedures and surgeries in Boulder County and our region are delayed in a number of hospitals. Our ICU and medical surge beds are insufficiently staffed to a great degree, and we are seeing increasing severe staff shortages, and we'll have more data on that in a minute. Also remember that cases affect other folks beyond hospitals, right? They affect health staff in schools, long-term care facilities, primary care providers, and many folks who are part of the health system beyond hospitals. And our BCPH EPI team is still in a surge response protocols. Despite the extra resources that we have received to respond to the COVID pandemic, our staff is still working overtime, nights and weekends to respond to the cases that we are seeing. In relation to goal 3, safely returning to normal activities, our aim is to minimize disruption and burden. We know that the masking order and vaccination rate are creating much safer public spaces than in many other counties. Businesses now also have the option to require vaccinations if that's something that they and their customers would like to do, and we're really trying to put the power in their hands to respond to their customers' needs and comfort levels. We are finding that kids are able to stay in school in Boulder County at a higher rate than many other counties in Colorado and the US, with significantly lower quarantine rate than last year. And we're continuing to work with businesses and other partners to find creative solutions to meet their needs, not getting too stuck on one size fits all, but really trying to work with folks to figure out what works for their needs. Just as a reminder, we use a variety of different kinds of responses. These are some of the ways that we try to get creative about how are we approaching situations. Recognizing that no one intervention is going to be perfect, but if we put them together, sometimes we can create much better protections. And just a final reminder that, our strategy and policy development inputs come from a variety of sources. They come from epidemiological information. They're informed by our community characteristics, by our local healthcare capacity, and by our public health capacity. And so there are a lot of little dynamics and considerations that go into trying to think about what makes sense, what's smart, what balances risks, safety, and comfort for folks that have, a huge range of different personal needs. So on that note, I will turn the presentation over to Michael Wu, our epidemiologist, one of our epidemiologists of Boulder County Public Health, to provide an update on the data.
Thank you so much. And thank you, Board of Health members, for this opportunity to present. Next slide. So first, in the context of Colorado as well as Boulder County, in comparison to the rest of our country, Colorado is sitting here at 185 cases per 100,000, according to CDC on October 6th, 2021. And just to give you some context, specifically, if we looked at Boulder County, that arrow gives an approximation of where our county sits in relation to not just these other states, but also Colorado itself. Next slide. So specifically with our 7-day cumulative case rate, we are at 160.8 cases per 100,000. We were seeing a decrease for a period of time and then some stabilization, but it does appear compared to last week that we have increased in our cases compared to prior weeks. Next slide. So specifically to also the counties that surround our county, most of the counties that surround us are also in high transmission. It means, that people outside of Boulder are also coming in for work and to enjoy, businesses. And so Boulder County is not isolated. And so, the case rates that affect the regions surrounding us can have an impact on our county as well. Next slide. So when we look at our age groups broken down, and this is the most recent data that I updated today. This shows that our highest case rate is actually occurring among our 0 to 11 age group. Over the last week, they've increased their case rate by a substantial amount. But not only that, our 75-year-old and older age group, which is in this dark brown line, have also jumped quite substantially in the last week. Next slide, please. And then also when we look at how our cases are broken down by our municipalities, over the last couple of weeks, we are starting to see that a lot higher percentage of our cases are coming from our Longmont municipality. And we know, Longmont also shares, or part of Longmont also exists in Weld County. And so, but these cases are specific to Boulder County cases that are in Longmont. But in general, across all of these municipalities, we are seeing a higher number of cases compared to the prior week. Next slide. And so what this slide is actually demonstrating is actually quite a celebration for CU Boulder. Over the first half of September, CU actually accounted for about 5.6% of our cases in Boulder County, but with their implementation of their vaccine requirements as well as their vigorous testing program, they went from that 5.6% of our cases to 4.1% over the last half of September. And then since the beginning of October, they now are accounting for 3.4%. And in addition, for some statistics regarding their vaccination rates, 95% of their students are fully vaccinated. 96% of their employees are fully vaccinated. So I believe that this is having an effect on their cases. And then next, talking about the health of our health system as well as our epidemiological capacity in our county. So for the North Central region, which includes 10 counties, including Boulder County, we averaged about 11% in terms of our staffed ICU bed availability over the last week. That is up from the prior week, which was 9%. And then when we're looking at the medical and surgical bed availability, it's still averaged around 11% compared to last week. But regarding hospitals and their staffing, more hospitals are reporting that they're having significant staff shortages compared to last week, so 30% to 23%. Next slide. And then what this orange line is demonstrating is our epidemiological capacity, meaning our ability to conduct full case investigations. And when we're above this line, it just means that we can't do the full workup of our case investigations with each case. It also means we have to prioritize certain cases as well. And like Lexi had mentioned, our staff is working quite hard, overtime and weekends in order to still try and keep up. And additionally, this line is actually really close to our high transmission line, according to the CDC. This metric is different because this is average number of cases versus a case rate. But this line is very, very close to that 100 cumulative cases per 100,000 threshold that the CDC uses. Next slide. So when we're looking at the deaths in Boulder County, so, for a period of time, in June and July, we didn't have any deaths, but, since the beginning of September, we've actually had 7 deaths. And one of them was associated with a long-term care facility. But overall, we have 273 deaths that have occurred among Boulder County residents since the beginning of the pandemic. And also, just to reaffirm what Lexi was saying, 3.3%, vaccinated persons in Colorado are 3.3 times less likely to become a case, and 8.2 times less likely to be hospitalized for COVID as well. Next slide, please. So this first slide is actually showing the positivity rate for all of Colorado. And we did see, this kind of slight dip and then a stabilization in September, and then we're starting to see an increase again in October for Colorado. And if you look at the next slide, this actually follows very closely to what we're seeing in Boulder County. For a period of time, we had dropped down as far as, I think, 3.6% positivity. But over the last 2 weeks, we went from 3.6 to 4.4 and then 4.7% positivity. And we're still maintaining about 2,000 tests done per day on average. So with regards to vaccination among our residents, we have 69.3% of our total population who are fully vaccinated, but that still means that over 100,000 of our Boulder County residents are still not fully vaccinated. Now, part of it are population that are less than 12 years of age who are ineligible, but that still leaves, majority of that 100,000 who are eligible to be fully vaccinated and are currently not. And I think that concludes my section, and I believe I'm passing to Lexi. Or no, sorry, to Trina.
Thank you, Michael. I'm going to provide a policy and legal context update, what's happening at the federal level, the state level, and the local level with respect to vaccine requirements. At the federal level, I'm sure you've seen in the press that the president asked for OSHA to issue a rule requiring all employers with more than 100 employees to implement a test or vaccination requirement. We don't yet have a deadline for this, but we anticipate this is going to impose a requirement on approximately 80 million individuals within the United States. On top of that, the federal government is going to be requiring the vaccine with no testing option for an additional 3 to 4 million federal employees and an unknown number of contractors. I wasn't able to track down that data. On top of that, the federal government will be issuing a rule anticipated to be in October, which is a vaccination requirement, not a vaccination or test, for Medicare and Medicaid staff for staff in Medicare and Medicaid facilities. That's approximately another 17 million individuals in the US. We're seeing similar trends at the state level. The state is issued a policy for all state of Colorado employees and contractors. That is a test or vax requirement, expected to affect about 130,000 individuals within Colorado. And as you'll recall, the CDPHE Board of Health issued a rule requiring all staff of licensed healthcare facilities to receive the vaccine no later than October 31st. And that's approximately 63,000 individuals within the state of Colorado. And just to put that even in more context, there's approximately 330 million residents of the United States. So that 80 million at that top there, you're looking about a quarter of the population, total population. On the local level, Boulder County has implemented a vaccine requirement for all of its employees. The city of Boulder has announced a similar requirement, and we know a number of our municipal partners are considering similar requirements. Boulder County, as part of our order, has a voluntary vaccine verification program, which allows for an exception to the mask order for those facilities and businesses that require proof of vaccination, and we'll talk about that a little bit more. Pitkin County has actually adopted Boulder County's mask order with the vaccine verification program as part of that. The City and County of Denver has a vaccine requirement not only for its own employees, but also for high-risk employers, such as healthcare employers, and I can't recall off the top of my head who else that affects, but there's a number of businesses implicated in that. And then, of course, the University of Colorado led the way in all of this back a couple of months ago by requiring the vaccine for all staff, employees, and students. Next slide, please. Relevant to all of this, we have upcoming at the federal level vaccine eligibility changes. The FDA has announced a meeting on October 26th to discuss emergency use authorization for the Pfizer vaccine for ages 5 to 11. Historically speaking, emergency use authorization has come 24 to 48 hours after that public meeting, but we anticipate it might be a little longer after this public meeting, simply because there are differences in terms of the dosing and the bottle requirements and needle requirements for the 5 to 11-year-olds, because they're testing a 10 microgram dose versus 30 for adults. Under age 5, we don't yet know when eligibility will be for that age group. We don't have an anticipated date at this point. And I'm going to pass it off.
President Thomas, staff and I at this point wanted to take pause to see if you or any other board member had any questions about the presentation thus far.
Can I jump in, Greg, with a question? Just, oh, yeah. Can I ask just about the increase in the 75 plus case numbers? And I'm gonna, again, based on the data of knowing that our 75 plus vaccination rate is really high in Boulder County, I'm gonna then jump to, are a lot of those breakthrough cases, and then did we have an outbreak that pushed those case numbers particularly high? And I guess this is a question for Michael, in the last couple of weeks, or not? I'm just trying to figure out why we're all of a sudden seeing a big case number increase among a highly vaccinated group of folks in Boulder County. And my kudos to you on the presentation, because it's really helpful and good stuff. So thank you.
Yeah, sorry, my child's outside my door. So with regards to the 75-year-olds, I'm currently not aware of an outbreak, but I just looked at this data today, and so I think it warrants some additional investigation. So you might have to get back to you on that. And also, was there a first part of the question? I might have missed it.
Just to respond to your question about the vaccination rate in that age group, yes, that age group has 99% vaccination rate. So these are breakthrough cases. Many of them are in long-term care facilities. We are planning to take a look and see if we can figure out what specifically has been happening. I'm not aware of an outbreak at this point, but we will definitely get back to you on that.
Thank you. I mean, yeah, that's what I was, again, what is concerning, right, is that even among a highly vaccinated group of older adults who are at higher risk for complications from COVID, this is concerning that we're seeing that increase. So thank you.
Right, this is Brooke. Quick question. So the 0 to 11 case rate, I might have missed this. How does that compare to the state as a whole?
We have some additional information coming up for you, Brooke. There's a slide that has exactly that information that will make it all clear in just a moment.
Got it. Thank you.
Hey, Lexi, could I ask Michael to go back to that slide? I just want to see what the timeline, the dates on that timeline are.
On the children?
Yeah, keep going back. Yeah, children. Well, the different age groups. Okay. So that goes back to July. All right. And then it was creeping up through the summer and then started to pick up again after school started. Okay. That's what I wanted to know. Thank you.
Michael, this is Lindy. And I'm going to ask some questions as a new board member, so if you could bear with me. I'd like to go back to the question raised by one of our community members regarding the CDC threshold. Can you talk to me about how we are looking at that CDC threshold and how that is driving our decision making from a policy perspective?
Yeah, so I think the one thing that I can say is that because the high transmission is so closely lined up with our epi capacity, shh, quiet please, sorry, that it really does impact the work that our own epis are able to do as well. But any other answers to that, I might have to get back to you, or maybe Lexi can answer that as well.
Camille, do you want to take it or would you like me to? Up to you.
You go ahead.
All right, so I think your question, Lindy, thank you for the question, is really about how did we come to decide on that threshold, on that particular threshold, is that right?
Yeah, I think exactly.
Yeah.
Right, for our county specifically, yep.
Right, so it's a great question, and I'm gonna actually go back to one of the first slides that we presented tonight, which was really this question about how do we develop strategy and policy decisions. And so, the number is the number. It's what the CDC recommends. Certainly that's persuasive to us. It's not the only component of our decision making. We really want to pay attention also to what is the point where our health system becomes overstretched, and we can see we are in high transmission. Our health system is extraordinarily stretched right now. Hospitals are, in fact, writing articles into newspapers asking people to get vaccinated. They have ceased to do non-emergency procedures. In fact, our hospital systems in nearby counties are even in worse situations, and we are having to really share resources quite a bit. So that's part of the equation. Are also really looking at what is it that our community needs in terms of feeling safe. And we do have folks who have, a variety of perspectives on this. We hear a lot from people who feel that they want to feel safe, and wearing a mask is part of what helps them to feel safe, and they express that appreciation. We confer with an awful lot of people before we make policy decisions about what they need. It's part of how we come up with some of our more creative interventions about how to support folks when we're working with long-term care facilities or schools or businesses or municipalities. And we also take into account, at what point do we feel like the number of cases is going to create a vicious cycle that we won't be able to contain anymore. And this is definitely stretching us as a community in terms of whether folks feel like it's contained. It's relatively speaking, we're doing better than other counties, but we are still in a situation where we are seeing multiple deaths a month right now in Boulder County.
Thank you, Lexi. Just another question related to what you just said is, can you help me understand, I'm not sure that I fully understood when you presented this and Michael presented this, how we're measuring true capacity in our hospital system. Can you talk a little bit more about that for me, just to make sure I actually understand what we're measuring?
Sure. So some of a lot of our hospital data comes from the state, and it's specific to our region, the North Central region. So it's based on the hospitals particular to the counties in our area, and it looks at a variety of indicators. Some of the indicators that we tend to report on a lot include staffed ICU beds, the number of staffed or percent of staffed ICU beds available, the percent of staffed medical and surgical beds available, the percent of hospitals reporting staff shortages. But there are a number of other indicators that go into the statistics that they report on a weekly basis that give us an indicator of the healthiness of our health system.
Okay, thanks. And then last question, I think I may have asked this in a previous meeting, but are we looking at our capability now that we have longitudinal data to some degree in terms of our forecasting capabilities so that we, can start to predict what we think might happen in future months?
It's such a lovely idea, and it has proven to be a bit of a folly for so many folks. The state is trying to make projections. It's very cautious. What we find is that as soon as we make a projection, the joke is on us, right? So it's difficult. It's because there are so many variables that are unpredictable, whether it's things that we can't control, like surges of cases in nearby counties, or a new variant that emerges, or a couple of outbreaks that just make a big difference. We are very cautious right now in predictions because the state has repeatedly told us that they do not feel comfortable making a lot of predictions right now about the course of this virus. Indira or Camille, did you want to add anything?
I'm sure Dr. Gujral can add more, but I would like to just also remind all of us that predicting is one thing, but also thinking about the seasons. It's about to get cooler outside. Perhaps people will spend more time indoors with each other. These are all part and parcel of our community and what we want the public health order to do, which is return us to a safer, normal participation in our activities, but we are also concerned. So that's not a prediction as much as it's just us knowing that people are going to not be able to dine outside as much, spend time outside with their families. And so we should be considering that as far as the community pull and how we all are working together to use the layered mitigation strategies. Dr. Gujral, do you have anything else to add?
No, nothing really to add. I just think that, the epidemiologic curves that we saw last year when people could not get vaccinated are going to be different going into this winter. We're more likely to see more cases, but fewer hospitalizations due to COVID. I think the problem to remember about hospitalizations is that Dr. Herlihy, who's the state medical epidemiologist, she presented last Friday on even 9 News and was able to share that, the problem is that 40% of the cases in the ICU are due to COVID. So under normal circumstances, when we don't have COVID, we would have plenty of staff and plenty of room in our ICUs. But COVID exacerbates things on the healthcare system because patients are often unvaccinated. They're also staying in the ICU for longer. They tend to be sicker. So I think that, like Lexi shared on this slide, we have to look at a multitude of factors. We can't just use one one metric to say, oh, yes, let's do this or that. So I hope that helps.
Yeah, this is very helpful. Thank you. I appreciate it.
All right, Lexi or Camille, did you say there are additional slides coming up on the agenda items of the review of the public health orders?
Yes, sir. We're going to move on, if there aren't any questions at this point, to a review of our universal masking order.
This is just a reminder that generally speaking, our mask order is linked to the CDC transmission tracker. And that when we are in high or substantial transmission, we're asking folks to wear masks when they're indoors. And we are going to have Trina Ruland talking a little bit more about, I'm sorry, it's not Trina, I apologize, Kate Haywood, who is working on our partner liaison team, will be talking a little bit about how the implementation of that order has been going.
Great, thank you, Lexi. Yes, as Lexi mentioned, we do have a business and partner liaison team that is specifically dedicated to responding to community concerns and following up on observed and reported violations of both the universal mask order as well as the school mask order. First and foremost, our enforcement action focuses on education, as the goal is to attain voluntary compliance first and foremost. How we generally achieve this is pursuant to observed violations or concerns reported by the community. Our liaisons will conduct extensive education and outreach with businesses by phone, email, stopping by the business, to the extent available, offering available PPE to the business, offering mask signs to the business, really just trying to provide any information and support that the business needs in order to attain compliance with the order. Following those initial efforts, we'll continue to monitor the situation. We will conduct follow-up site visits if deemed necessary, and then we will also continue to monitor the community concerns. If we continue to receive concerns following that initial education and outreach, we may follow up with a written notice of violation. We have several template documents that may be provided to businesses based on the documentation of the violation and the severity of the violation. So we have a warning notice. We also have a notice of violation. If after the education, outreach, issuance of the warnings, the notices, if we've reached a point where no additional support can be provided, it's really just a determination that the business is willfully violating the public health order. We can proceed to filing a civil suit against that business seeking injunctive relief from the courts. And over the course of the pandemic, we have had to seek judicial intervention 4 separate times, and we were successful in each of those actions. Although with respect to this current universal mask order, we have not needed to escalate enforcement to that point. We've been really successful with our education and outreach, and there are a few businesses that have received more than one notice of violation, and we're in very close contact with those businesses and monitoring those situations very closely. I asked the team just to pull together some data for the board just to see the volume and how things are progressing on the enforcement and education side of things. I have the dates of this data below, but since the issuance of the universal mask order through September 29th, there were 579 calls to the call center. Through October 4th, We have, the business team has responded to 175 concerns from the community regarding mask order violations. We have conducted education efforts with respect to 50 of those businesses, and we're able to bring them into compliance with education alone. We've issued 26 warning letters, and then we've issued 23 notices of violation. And while that data just kind of paints a broad stroke, a bird's eye view of the enforcement action, there's a lot of work going on the ground. We have a really active team, and overall things are progressing really well. We're getting, really positive feedback when we are engaging with the community and businesses. And I'm happy to answer any questions the board might have.
Kate, are the NOVs, the 23 NOVs, part of the 26 warnings?
No, those are separate.
Okay.
There are.
It's only for NOVs. Okay.
Yeah, it is likely that some businesses that have received both, and I don't have that broken out, but those are two separate types of documents.
Lexi, are you making sure I'm on? Hi, I'm Tessa Hale, and I'm here to talk about the vaccine verification program. So this slide is one that Lexi had shared with you all on the September 2nd meeting, talking about the different kinds of employer and visitor vaccination policies that have been happening. And I'm not going to go through this in detail again, but just to kind of bring you back and remind you of the thinking behind adding this to the public health masking order, as this is an option for a voluntary program for businesses and facilities that wanted people to go without masks. And so people who have employed vaccination policies, which I saw today that Bloomberg did a survey of large employers, and 50% of large employers across the country have implemented some kind of vaccination policies, and it is attributed to an uptake in vaccines nationally. But it creates a safe place for employees and customers to know that they're in a place where there's lower likelihood of transmission, that it increases the uptake of vaccination. It can help us get back to a normal more quickly and for the longer term, as opposed to a temporary public health order. It's been a great way to protect the workforce, essential workers and frontline workers who are regularly interacting with the community, to be more safe. And it can be developed really flexibly, like our program is, which I'll get into more detail lately. And it helps to create a sustainable system for maintaining high community vaccination levels, like our other regular vaccination schedules that we see in the community and as we have for years. And so things to think about with these kinds of policies is about early adopters to build momentum. And we're really excited that this program has been really well received in the community. And I'll have a chance to share some numbers with you about that. It is voluntary. Not everybody has to do it. We built it to fit those facilities and businesses that are interested in it. And it's really important that we're supporting employers so that people have accurate information about vaccinations, the safety of them, that we are able to reach all different people in the community, that it has an equity focus, and that we're able to provide access to all people who are interested in getting vaccinated. Next slide, please. So the vaccine verification program, you all might remember when we talked about this previously, we called it the Fully Vaccinated Facility Program. The reason we changed this is because we were really listening to the community and thinking about employers and their legal responsibility to ADA and requiring exemptions for medical and religious reasons. And so for that reason, rather than being 100% vaccinated, we decided it would make sense that in some instances, not everyone in a facility can be vaccinated. And so we wanted to account for those accommodations that needed to be made. So the program launched on the 24th of September. And this was, just to take a step back, the day after the masking order was put in place on the 2nd, we did launch a temporary self-attestation program for those businesses that were already participating or had already implemented a vaccine mandate for their facility. So the full program was launched on the 24th, and we invited facilities to apply on our website, and essentially there's 3 main requirements to participate in the program. One is that facilities have a written policy, that they discuss how they'll achieve the 95% vaccination rate for those individuals in the indoor space, and that they discuss the additional mitigation strategies that they're employing to ensure the safety of people who are in their space. And so the process for this is that a team from Boulder, BCPH, and a contractor H2 are reviewing applications, and some are very easy to see. It's a small staff, there's no outside visitors, it's a quick pass. Sometimes we have to reach out for additional information, and other times it doesn't meet the criteria, upon which we also try to work with businesses. The goal of this program is for any facility that's interested in participating, we want them to succeed, and so we're working closely with those facilities that do apply. We've had a great turnaround time. We have amazing people working on this program, and so within 1 week of applying, for the most part, people have received feedback on whether they've been approved or need more information. People, upon approval, receive signage. This is an example here on the slide where it would say proof of vaccination at all times, or this is representative of our hybrid option, which is for places that have a part of their space that's fully vaccinated, or it's at certain times. A gym or fitness facility may have certain classes that are fully vaccinated. So this is something that's available in English and Spanish. And also, we are listing the facilities that are approved on our webpage. Next slide, please. So we did a lot of outreach because we really wanted to let the community know about this. And so the 111 facilities that had done the self-attestation received information about this. We had several, Boulder Chamber hosted several cross-industry webinars, and we also had a special webinar for just gyms and fitness facilities for this. We presented at the Boulder County Economic Recovery Team, agency administrators. We've sent targeted messages to all restaurants and body art facilities. We'll be reaching out to our PACE partners. And then as we see the demographics of who's participating, we'll develop a strategy of who might not be receiving the message that this program is available. Next slide, please. So this is just the outcomes to date. So we've had 204 applications, 188 have been vaccine verified, which we're really excited that just a few weeks in, we've had this level of uptake and success. Next slide. This represents by municipality. As you see, the majority of businesses are in Boulder and then Longmont, Louisville, and there's been a few from our smaller towns in the county, but we're again hoping to continue to work with our municipal city partners on pushing this program out. Next slide. And then these are the different kinds of facilities who are applying. As you'll see, it's primarily offices and small businesses. These are ones where I think it's really easy to implement. Then next we have gym and fitness studios, events, community center and houses of worship. We've had a couple of restaurants, a couple of retail, and then the other are things like therapists, art studios, special one-time events fall into that category. And the next, please. And so, as I mentioned, we do have all of these facilities are listed online. We've heard a lot of great feedback from the community that they're excited to know that they can look to see where they could go, where it's a fully vaccinated facility. And anecdotally, we've had, it's been exciting to hear from a few businesses that have said that either they've had additional staff get vaccinated or they've had guests or clients who have decided to get vaccinated for this program. So overall, we feel really positive about the way that it's going.
Thank you, Tessa. President Thomas, do you or the board members have questions about this portion of the presentation?
No, I'm glad to see it's rolled out and glad the thought and the outreach that's gone into it.
Looks like Member McMillan might have a question.
Yeah, thanks Tessa for going over all the information. And again, I'm excited about the program and I'm glad to hear it's being well received by businesses in the community. I'm curious about whether or not there's a recommended software or something that's being used for verifying people who are coming into the building. I know that's been a challenge for businesses nationwide, just in terms of not having a consistency of tools. So I'm just curious if you all are recommending something or if there's something being used consistently.
Yes, thank you for that question. That's a great question. So, again, just to be as flexible as possible, we're saying to employers or to facilities that it could be the actual vaccination card, it could be a photo of the vaccination card, it could be a copy. The My Colorado app is really fantastic, and we're saying that that's an option. And then we're also letting the community share with us what works best for them. So in the fitness community, MindBody, there's several different third-party apps. I think restaurants have some apps that they've been using. And so we're also in partnership with the Boulder Chamber, who's coordinating chambers and across the entire county, trying to have some information sharing around that so that businesses aren't having to start from scratch, but really able to learn from each other about what different kind of apps are working well.
Great, thank you.
Thank you, Tessa. If there aren't any other questions, we still have more to bring to you, specifically about our public health order on school masking and an early childhood and K through 12 update. So we'll keep moving forward, and we'll also have time for questions after this portion of the presentation.
Okay, thank you, Director Rodriguez. So I'm Indira Gujral, and I'm going to be joined today with our County Attorney Trina Ruland, our K through 12 Policy Liaison Taylor Carranza, and our Early Childhood Education Epidemiology Lead Elena Younger. So we are a small but mighty team, and so we're going to present to you about some of the most recent literature on masking in schools that are influencing some of the national and state policies. And then Trina's going to just give a quick update on what's happening with those policy changes. And then we'll move into Taylor and Elena's presentation. So next slide, please. So I wanted to present to you two updates in the literature. The first one is a Morbidity and Mortality weekly report that was recently released. This comes out of Arizona. It's Maricopa and Pima counties, which those two counties in particular represent 75% of all of the state's children, the K through 12 population. So these are large counties, and data were available for 98% of those K through 12 public non-charter schools. And the districts had varying mask policies, with 48% not having any mask policy. And out of the 191 outbreaks that they looked at between July 15th and August 31st, 48%, almost 60% were in schools without a mask mandate. And so when we look at the odds of an outbreak and we adjust for, factors such as school size and grade level and county level, the odds of an outbreak were 3.5 times higher in those schools without a mask requirement than compared to those with an early mask requirement. And so the CDC does use this as a foundational study to help guide and demonstrate that masks are effective in preventing spread and outbreaks. Next slide, please. So this is a second study that was done, also published in the Morbidity and Mortality Weekly Report. And this looked at 520 U.S. counties across the whole country. And it looked at counties between July 1st and September 1st. And these are counties that had started school, had available information about mask policies, had a mask a policy available for the at the county level, and had 3 weeks of case data before and after school had started. So of the 520 counties, 38% had a mask a school mask requirement and 320 did not. So those with the mask requirement are in light blue, and those without the mask requirement are in dark blue. And the left side represents the 3-week time period before school started, and on the right side is the 3 weeks after school has started. So when they compared the pediatric COVID case rates during the weeks before school started and after school started, you can see that the counties without a school mask requirement experienced a significant increase in the number of cases. And then when you look focus just on the right side, after the start of school, counties with mask requirements, that again, those in the without a mask requirement, those in the dark blue, experienced larger increases in COVID cases rates compared to counties with a mask requirement. And so this was after controlling for lots of covariates, but really what the essence here is saying is that schools who started early with mask requirements are seeing less cases and less outbreaks. And this isn't just happening in Colorado, this is happening in other states and happening across the country. Next slide, please. All right, Trina.
Just an overview of what we're seeing with mask requirements around the state of Colorado. Boulder County Public Health issued its school mask order in early August. We were one of the first public health agencies to do so. Since that time, 78% of the pre-K through 12 students in Colorado now have a mask requirement in their school. That's all of the metro counties now have a mask requirement, and a number of school districts whose public health agencies declined to issue a county-wide requirement went ahead and issued a school district-based requirement. CDPHE also updated its recommendation on September 10th, recommending universal indoor masking for all schools. This was a change. They had some strange, complicated formula prior to that date. But on September 10th, it was universal indoor masking. So we are now in alignment with that. Next slide.
Okay, next slide, please. Thank you, Trina. Okay, so we have been able to demonstrate and show, and Michael presented this earlier, the percent positivity for the whole community. But I want to thank Steffi Goodman, who's put most of these slides together. She was unable to present today because she was out. But this is a really important slide because it shows the percent positivity of the tests that are taken by age group. So when you look at the bottom of the column, you see the age group and you see the total number of tests that were taken between August 18th and October 4th. So really kind of looking at since school has really initiated and started. And we're doing really well with our community-based testing for all age groups because we're under that 5%. But we're really, the highest percent positivity rates are among those 15 to 17 years of age, which also coincides with them having the lowest number of tests. So we are definitely feeling like outreach to this age group, to that high school age group, about when people are experiencing symptoms is going to become even more important, particularly as we enter into flu season and we see lots of respiratory viruses intersecting with COVID and having similar symptoms. So we are definitely going to be working with our school partners on that. Next slide. And just taking a closer look at the case data, and I think one of our board members had asked about what was happening with the age groups. So in Colorado, the case numbers among children continue to remain elevated. The 6 to 11-year-olds continue to be the highest and surpass more the other age groups. And what we're seeing really, and we speculate, but it's the product of, this group is not vaccine eligible. They are in school settings, which means that they're closer to peers and people may be sick and they don't know. And then there's varying mask policies that are happening across the state. So this is statewide data. And then you throw on top of it the Delta variant, which we know is 2 times more transmissible. So it's actually not surprising that we see these high rates in that age group. And we're hoping that with the vaccine campaigns coming out for this age group, hopefully in early November, that those vaccine campaigns will help to start to ameliorate what we're seeing here. Next slide. So this graph is different than the state slide that we just looked at, and it's really different on the y-axis. So on the last slide we looked at, it was looking at an incidence rate. On this slide, we're looking at a 7-day rolling average case rate. So that means how many cases are we seeing per day per age group. And in Boulder County, we're seeing an increase among those that are 0 to 4, which are kind of in that, we were seeing increases across all age groups. But the 5 to 11-year-olds, which are in the light blue, that is peaking upwards, they are averaging the most. So we're averaging around 7 cases per day in the 5 to 11-year-olds. And we had Michael looked at the numbers today, and 1 in 4 of our cases every day is among children who are less than 18 years of age. So that's 25% of our cases are among children. So we know that they are at risk. And one of the things I do want to point out here is those that are 12 to 14 in green and those that are 15 to 17. We see some variability with them, but the good news is that almost 70 to 80% of them are vaccinated. So it's my hope that over time, the vaccines, as we get more people vaccinated in those age groups, that we'll see decreases. Next slide, please. And how do we compare to all the other counties? Well, if we look at the counties along the Front Range, we're actually doing pretty well. So Boulder is down there at the bottom. It looks like my circle moved a little bit. Sorry. And we have a mask mandate in Boulder County. Some of these other counties do as well. And it should be pointed out that even like El Paso and Larimer, they may not have a county mask mandate, but some of their school districts have put in place some mask requirements. So what it's difficult to kind of take a look, but we know that as a community, we are doing very well compared to our Front Range partners. Next slide, please. So we've demonstrated this slide before. It looks at a comparison of 2020, which is in the solid lines, to 2021, which is in the dashed lines. And this is the 7-day incidence rates among the 4 different age groups. So 0 to 4, 5 to 11, 12 to 14, and 15 to 17. And the differences between what we saw in 2020 versus 2021 among these age groups, they are statistically significant. The differences are statistically significant. And that's really important. But it's also important to remember that in 2020, last year, we started the school year remotely. We were dealing with the wild type strain. Vaccinations were not available for some of these age groups. And, it was a different kind of approach. So when we take a closer look, we'll see that these differences are going to be very similar for all the age groups. So let's go to the next slide. So the next slide shows the 0 to 4 age group in 2020 in that solid line and 2021 in the dashed line. Next slide is the 5 to 11 age group. Next slide is the 12 to 14 age group. And the next slide is the 15 to 17-year-old age group. So the circumstances were different in how we started 2020 as compared to 2021. And we have different challenges in 2021, particularly with that Delta variant having higher transmission rates. So just wanted to point that out. Next slide, please. Okay. In terms of our comparison of 14-day case rates and vaccination rates, so on the left is the case rates, on the bottom is looking at the share of the population that's fully immunized. Boulder is doing quite well. So we know that our higher vaccination rates lead to lower case rates, and we're seeing that with our 12 to 17 population. Next slide, please. And this shows up with our vaccinations. So we started to untangle or pull apart the age groups a little bit more. And when you see the 12 to 14-year-olds, they're about 72%, which is good. 15 to 17-year-olds We started to pull them out, and they're close to 70%, which is good. So those are your high school juniors and seniors. And then when we look at our 18 to 19-year-olds, we are not doing well in here. So we're only looking at 48% of them, and that's in that orange box on the left. 48% of them are vaccinated. So a lot of people get confused because they think, well, CU and Naropa and Front Range, you know, they put all these vaccine mandates in place. That's true, but we have to remember that not everybody goes to college. Some of our, you know, county residents who are 18 and 19 are going straight into working environments. And so it will be interesting to see how the vaccine mandates over time will impact this population. But we are very concerned about it, which is why we're working very closely with our community ambassador groups to make sure that we do some targeted education and making sure people know they have access. We've actually started giving $100 gift cards for people for first-time vaccinations. And so we're hoping that those incentives will help. And then just to prepare for the pediatric vaccinations, we know about 23,500 of that 37,000 there will be eligible for vaccinations coming up in November. So lots of work to do still on this front, and working with our community partners. Okay, I think that's it for me. Taylor?
Thank you, Dr. Gujral, and thank you, members of the board. I'm going to talk a little bit more specifically about what we're seeing in the schools in relation to the masking policy and layered mitigation policies order that we have in place. So if you could show the next slide, please. Important context, we get a lot of questions about the data that we report around schools, and we felt that it would be helpful to provide that context about some of the limitations around this data in general. One of the key things that we're going to spend a little bit of time talking about is comparison to outbreaks. But it's really important to recognize that the state changed the outbreak definition in the previous year for all outbreaks, not just school, but it's greatly impacted our ability to compare school data from last year to this year, increasing the size and threshold of outbreaks. So we can adjust for that, but when looking at statewide data, it's important to keep that in mind. In addition to that, we're unable to report cases by school district or school specifically, and that has to do with knowing where every student is enrolled. And that is just a consistent limitation that we continue to have. So that's why most of our data is broken out by age or by municipality, as opposed to by location where the student goes to school. In addition with that, there are challenges with gathering quarantine numbers. This has to do with the way that the quarantine system is set up due to capacity, where most quarantines are conducted by our school partners, but that has not been uniformly tracked through the state system that was set up last year. In addition to that, we are unable to precisely compare the districts within the county or across counties for a lot of the reasons that were highlighted before. It's much easier to compare a district over time. Or we get a lot of questions about the outward reporting on the district's websites, and they set those definitions. So there's some minor differences in those definitions. So when comparing those outwardly reported numbers, it's important to keep that in mind, that they're not all reported the same way. So we try and collect that and uniform it, but it's not we get a lot of questions about those websites. And then lastly, it's important to recognize that the classroom context is constantly changing. So in addition to the policies that we have enacted, there are more students in class this year than last year. So classrooms are denser. There's less hybrid teaching. There's all various different changes in the classroom context constantly happening. So we're having to adjust for that and take that into consideration when we're looking at what trends we're seeing. Thank you. Next slide. So this first piece is after Dr. Gujral shared the trends in cases that while we are seeing significantly more cases in youth ages this time as opposed to this time last year, based off of our reduced quarantine approach that is a part of the public health order in Boulder County, we have been able to significantly reduce quarantines while still prioritizing safety and limiting transmission. This slide in particular, the left column is, so this is specifically 91 cases occurred in BBSD and St. Vrain in the week listed here of October 1st through October 7th. And as a result of those 91 cases, in partnership with the school partners and case investigations, 108 students were quarantined. as opposed to we estimated looking back at that week and the ages of those cases and what the previous year's guidance under CDPHE was. And we estimate that would have been about 364 quarantines. So as is highlighted here, we've been able to reduce in this particular week, which was a pretty average week, quarantines by a little over 2/3. So significant reduction in quarantines and focusing in on the places where we're most concerned about transmission in those classes. Next slide. As Dr. Gujral highlighted, this is the proportion of our cases each day that are by age group. And the line, the dark blue line, it's a little hard to see, is the 0 to 17 line, which, as Dr. Gujral highlighted, is about a quarter of our cases daily. So it's important that not only does that impact the number of students and the transmission and transmission control approaches, but also important to remember that, or as I said, that a lot of the case investigations are done in partnerships with schools and particularly their health services, and high levels of case numbers is impacting staffing capacities. And we want to keep staff available to be providing the other crucial services that they are providing in school settings. Next slide. So this is a depiction of statewide trends and outbreaks over the last year and a half, I believe, with the orange color representing K-12 and ECE outbreaks. There's a significant reduction in outbreaks now as opposed to this time last year or a little after this time last year. And it's important, as I highlighted earlier, that that is possibly reflective of the change in the outbreak definition. But also, as we're seeing, even with that, schools are taking up a larger proportion of outbreaks. It's really schools and residential healthcare that are the largest proportion of outbreaks, as we're seeing. And you can see the section that's highlighted with the return to school. Next slide. And just looking more specifically at the numbers for the North Central region, so the region we are a member of, that number breaks down to about 37% and is actually the largest proportion of outbreaks in our region for the time period highlighted here. Next slide. So what does this mean in relation to our order? As Trina highlighted earlier, the vast majority of students in Colorado are actually following a masking order, whether it is a county order or a policy at the school or school district level. The challenges with tracking that information is that the state is not collecting exactly which schools are requiring masks and which are not. So we were able to look at a county level of which counties have mask orders, but that is important to keep in mind that the school level masking is not reflected in this. But as of the week of 9/29, this data is updated weekly. So for the outbreaks that were reported as of 9/29, there 122 of the statewide outbreaks were in schools that were in counties without a county masking order covering schools. And 40 of the outbreaks that were reported were in counties that did have masking orders. And this is specifically K-12 ages. Next slide, please.
Taylor, what are the numbers in parentheses?
Yes, those are the total numbers of cases affiliated with those outbreaks. So those are the number of students that were tied to those outbreaks.
Thank you.
And then this slide shows the average number of cases. So taking that number and breaking it down, average number of cases in each of those outbreaks in the categories. The orange category is counties that had mask orders that either changed in the time period or that they had partial mask orders that didn't cover every student in their county. So for such as 11 and younger. But as you can see, the largest number is 16.6 is the average case size for counties without masking, and counties with full universal masking orders, the average outbreak size is 10.9. And next slide. So generally speaking, when we're looking at the set of data there, talking from the high numbers of cases that we're seeing while reducing quarantines and then keeping our outbreaks low, and which is one of our biggest indicators of transmission, in addition to our investigations, we're able to see that even though we have more cases, we are preventing transmission while keeping more students in class, which was our ultimate goal with this order. That is in large part a huge thank you to our partnerships with independent schools and school districts, as well as childcare facilities. It remains to be one of our most effective tools. And in particular, as Dr. Nolan highlighted at the very beginning of all of this presentation, when we're not just balancing data and epidemiological trends with systems and staffing capacities and the limitations of physical spaces, which is quite a real problem in school buildings. So that's been a really great success. People may have seen that there was an update in the CDPHE guidance between our issuance of our order and now. Just in case folks have questions about that, there was not too many significant changes in that guidance that affected Boulder County specifically. We do deviate from CDPHE in a couple of ways, and when that guidance was updated, we collaborated with our partners again to verify and review those pieces and made decisions to stick with our existing order because it's been effective in our county. Reduced quarantine approaches, as I said, have helped keep more students in school. As we looked at just one particular week, we were seeing that across the weeks where we're keeping more kids in school and less interruptions to classrooms. And then lastly, adjusting for the approach sorry, so that piece was added there. Reduce quarantines and outbreak situations based on transmission data from the first few outbreaks. We are going to be adjusting just a couple of key pieces of our order to fine tune and hone in and further reduce quarantines on that might be unnecessary. I see there is a hand up. Is that a number?
Hi, thank you, Taylor. This is Morgan. And I have a question about testing. So I know that at least in BVSD, and I believe in St. Vrain, is there a regular testing program going on in schools that parents can opt into? And I'm wondering if you know the data on how many, like what percentage of parents are opting into that program to have their kids regularly tested, and how many cases are being identified through regular testing versus, symptomatic testing that is happening because they're seeking out the test, not through a school testing.
Yeah, if whoever's in control of the slides wouldn't mind going forward 2 slides, I have a slide on testing, and that would be perfect to talk about. So perfect, great question. One, just a reminder to everybody that there is free public testing available through Boulder County Public Health. But also in addition to that, as you highlighted, both BVSD and St. Vrain are working with COVID Check and have community testing sites available to the public as well as to their students and staff. And in addition to that, I know BVSD is doing a mobile testing program where they bring a mobile testing unit to every school every 2 weeks for just routine surveillance testing that students and parents can opt into. And then in addition to that, when we do identify an outbreak, they'll bring their mobile testing unit to that school to do some quicker prioritization of testing in that community so we can identify trends. Part of the testing program that you might be referring to is there is a statewide surveillance testing program for schools. Unfortunately, ECEs are not eligible for that program. Some of our independent schools here in Boulder County have enrolled. However, the program does have some logistical challenges. And with the local testing being so robust, both school districts have felt that the statewide program would not be meeting their needs. So currently they're leaning on their existing testing processes. In addition to that, there are Binax Now at Home tests available, both in many pharmacies as well as through the state. And I provided a link in the slide deck for folks to find that state program. But if you just Google CDPHE Binax tests, it takes you to that page and people can order it for themselves or for their organization. So there are more and more opportunities for folks to be tested. In terms of our people being caught or our cases being captured in those testing programs, yes, we have definitely had situations where a classroom received an exposure notice and the family went and followed the recommendation in the letter and got tested, and we found additional cases that way. So it has been very helpful to have testing more and more available in the community. I hope that answers your question. If we could go to my one previous slide, I have one last set of updates, and then I'll pass it off to Elena Younger. So a little bit more, as we know, that our masking order has been in effect since the school started. Since it's been in effect on August 10th, but school started roughly the week of August 16th. One of the changes that we're looking, the small changes that we're looking at making to the order is that right now we estimate that 90 to 95% of Boulder County schools have a medical exemption rate, masking exemption rate of less than 3%, which is great. There are several schools that are above that 3%. We estimate, as I said, about 5 to 10%. Part of this addition would be a requirement of that reporting, so we could have a more accurate understanding of who does not. I don't want people to jump to the misunderstanding that that immediately means that somebody isn't following the policy or the order. We have a lot of schools in our county that serve students primarily with disabilities or have large populations with students with disabilities. But we have found that there has been 6 active outbreaks in schools at this point. And many of those outbreaks have been traced back to masking lapses, whether medical exemptions or individual lapses of masking. Or individuals that were symptomatic and infectious while in school. So we are planning on requiring schools to report their medical mask exemption rates, and schools above that 3% threshold would have to work directly with our team to create an individualized plan to add additional layers of mitigation since less of their students are masking, to try and address that gap there. And then just a general reminder to everybody, even if you think it's allergies, please stay home and get tested. As I said, we've had a couple of folks who that's been the case. So if you're not feeling well, stay home, get tested. And it's really important for keeping as many people in school as possible. So that is my section. I'll pass off to Elena Younger, and then I think we'll open up for a bunch of questions about all of this. I know it's a lot of information.
Thank you, Taylor, and thank you, board, for your time. I appreciate this opportunity to present an update on trends we are seeing in our childcare community. Next slide. So our first graph depicts the number of individuals who work in or attend Boulder County childcare and have tested positive for COVID-19 by week. Cases among children are represented by the green columns, and staff cases are depicted in orange. The volume of cases of Thanks. The volume of cases of COVID-19 in Boulder County childcare settings has risen since the summer and remains high today. Since August, there have been an average of 9.3 exposure events per week in our childcare facilities. The majority of cases are among children who remain entirely unvaccinated in this age group. This increased frequency of exposure events has led to a rise in the frequency of quarantines for childcare attendees and unvaccinated staff. The majority of these exposure events lead to classroom-wide quarantines. In a given week, there are on average between 15 and 20 classrooms or cohorts under quarantine orders. However, childcare facilities do have the option of shortening quarantine to either 7 or 10-day periods to reduce the time children and staff are out of care. And these quarantines have been effective. Between mask wearing and the use of quarantine, we have seen minimal secondary spread in these childcare settings. So to summarize, while there are more individual cases of COVID-19 in childcare due to high rates in the community, there is minimal spread happening between those cases and healthy children and staff under our current policies. Next slide. This next graph depicts the number of confirmed COVID-19 outbreaks in childcare settings before and after the public health order went into effect. As Taylor mentioned, the outbreak definition was changed in June 2021, so our team retroactively applied the current confirmed outbreak definition to outbreaks prior to the definition change, so that all of these outbreaks depicted here are under the same definition and allowed us to make this longitudinal comparison. The current number of exposure events in childcare is notably higher than earlier this year. Between March and the first week of August, right before the public health order went into effect, there were 3.4 exposure events per week on average, compared to our current average of 9.3 exposure events in childcare per week. Despite this increase in the frequency of exposures in childcare, there has been a decrease in the frequency of outbreaks since the PHO was enacted. In fact, there have been 0 confirmed COVID-19 outbreaks in childcare in Boulder County since the public health order was enacted. Next slide. Accordingly, there has also been a decrease in the number of childcare outbreak associated cases since the public health order went into effect, and that number remains at 0. Next slide. Okay, so overall, masking has been well received. Children as young as 2 are successfully wearing face coverings, and childcare providers have adopted creative approaches to implementing and reinforcing mask wearing in the younger age groups. Despite an increase in weekly exposures compared to the time period prior to the public health order, secondary transmission has been minimal and no outbreaks have occurred. Isolated instances of secondary transmission have occurred and have largely been attributed to inconsistent mask use or settings such as infant classes where they're too young to be wearing masks, or working or attending care while symptomatic. And finally, we do recognize that while effective for disease control, quarantines do have impacts on families, especially when parents need to remain home to take care of children in quarantine. So with that in mind, we are actively seeking feedback from our childcare partners and discussing potential opportunities to scale back the frequency of quarantines after exposure in childcare, like what K-12 has done in many settings. However, reduced quarantines in childcare are currently not supported by CDC or CDPHE guidance, so we are exploring this option with care and in light of the data to ensure that it's rolled out in an effective and equitable way. Thank you. That's all for me.
I think this is my slide, but just summarize everything that we've talked about in schools, both childcare and K-12 settings, is that we are seeing more cases in younger age groups, which is and more effect on younger age groups, as we talked about, with more hospitalizations in younger age groups in the last quarter or the last 6 months than previous to that. Mandatory masking in schools has reduced in-school transmission. We have seen less transmission, and it's especially when we're looking at comparing our county to surrounding counties or some of the literature reviews and case studies that Indira shared, Dr. Gujral shared. That case numbers are lowest among schools and districts and counties with mask policies, as I just said, and ultimately that we are meeting our goal to keep students in class while keeping them safe. We are seeing less transmission. We're keeping more students in school, even with these increased case numbers. And we're working on addressing those places where we are still having high numbers of quarantines, as Elena highlighted, by trying to work with our partners and see what opportunities there are to do that safely. So thank you very much.
So looking ahead, I want to remind all of us as to what Dr. Nolan started off this presentation as, to focus us on our goals. Our first and foremost goal in both public health orders and in all the work of the recommendations of the use of layered mitigation strategies during this pandemic included preventing severe illness and death, not overwhelming the system, and safely returning to normal activities so that these efforts that we are putting in place keep us with the ability to go out and about instead of experiencing more severe closures or stay-at-home orders. Next slide, please. I know you've heard a lot of information this evening, and we are going to open it up one more time to Board of Health members for discussion or questions. But we didn't bring any actions to you this evening. It was our goal, as you asked us to bring you data on this school masking order, as well as to summarize how the universal indoor masking order in public spaces, how it was going, how it was received, and how the vaccination verification program was progressing. We feel we are relatively successful with the school masking order. The data shows that schools with masking orders are having more success at keeping kids in school. As you can see from this slide that I will not read to you, but these are a summary of what you've heard tonight. You know, we are still in high transmission, and it will take time to move to moderate, but we're very hopeful that the continued perseverance of this community, the participation of businesses and employers in implementing vaccination policies, and of our collaboration with school partners and with hospitals will continue to have a positive effect on cases in this community, and as well of policies that are outside of our control, which include the ability of our children who are younger than age 12 to be vaccinated. And when that approval occurs, I think we will also see some changes in those numbers. We know that it is time for more indoor sports to occur, more indoor time, as I mentioned earlier in another discussion. And so I think we have to be aware of how important it is to continue with layered mitigation strategies based on some of those particular issues. And our partners at the state, CDPHE, are really urging us not to make any changes, at least until January, to assess holiday impact, just to ensure that we watch our case numbers after people are gathering for Thanksgiving and Christmas. So we will continue to collaborate with partners, with our school districts, with independent schools. And finally, we don't talk about this probably enough because we do it so much, but the regional local public health department administrators are regularly discussing continued efforts to implement a regional strategy relative to school masking orders, and we continue to urge, as many have followed, but we continue to urge, and we thank Pitkin County for following our lead, but urging even universal indoor masking orders to stop the spread of COVID-19. So with that said, President Thomas, I know perhaps the board has any more questions or comments for our amazing staff who put obviously so much effort into this presentation for you this evening.
Ooh, that was a lot of data. I mean, we've seen several of these presentations over the last year. Man, my head is spinning. Kudos to the staff and management for really kind of putting that together. I think you did address a lot of concerns, questions we heard in previous public comment sessions, especially related to kids and schools and masks. Yeah, I mean, let me gather my thoughts here, and I'm sure we have plenty of other questions from the board.
Yeah, this is Brooke. I have a quick question. Thank you, all of you. This was very detailed, and I think you answered all of my questions that I had over the course of the presentation. I did have a couple questions. The first one was, in Indira's initial presentation, when you compared the counties and schools with mask mandates versus those that did not have mask mandates and the case counts, any idea of if those unmasked schools also had quarantine protocols? And my curiosity is it more the masking, or is it the masking plus quarantine protocols, or is it quarantine protocols? Like, what are the big contributors there?
That's a question. I'll have to go back in and take a look. Was that the Arizona study or the second study?
Yeah, the Arizona study.
Okay. I will go back and take a look and email that back out to the board.
Thank you. And I had one other question too. So just to get some clarification around what was brought up in public comment, why have we decided, when there is a discrepancy between CDC and WHO, why have we decided to go with the CDC protocol of 2 and up versus the WHO protocol of 5 and up?
Hi, I'm happy to take this, at least to start. Again, this is Elena Younger, the CE epidemiologist. I wanted to make sure that we follow both CDC guidance and also took into consideration what the American Academy of Pediatrics put out. And the American Academy of Pediatrics also shared that mask wearing is safe for all individuals 2 and up. So between those two primary sources, which are strong sources of reliable information for the United States, that's where we took our direction for Boulder County.
I'll also add that there was a letter from the Colorado Association of Pediatrics. I can't remember their exact name, but they also strongly recommended it for age 2 and over.
And for those counties in Colorado that do have a mask mandate for schools, are they primarily going with 2 and up?
I can speak to the Denver metro area, and the Denver metro area is 2 and up, and that's a large part of the population in Colorado. I have not looked specifically at county orders outside of the Denver metro area.
I can add a little bit to that. There are a couple of counties that are 3 and up. I've run across 4 at this point across the state, but I can't say that that's all of them. The majority that have a mask order, it's 2 to 11 or 2 and up.
Got it. Thank
you. I have a question. So I know I've received probably 5 notifications of a possible, my son was in contact with somebody. And so in those cases, is that notification sent when it's a student test positive in his cohort or in his classroom? Or could it be like couple layers of a couple degrees of freedom between, could it be like a friend of a friend tested positive? I'm just like wondering, where does that notification chain stop?
So that is for either staff or student that has been in the classroom or in an activity with your student. We've gotten a lot of questions about that. The letter that says that there was a positive case in a classroom is not the quarantine notice, and somebody who receives only that letter without additional communication is not deemed to be a close contact that needs to quarantine. But we do want to make sure that folks are aware that there are cases. People have a right to know about that, and remind them that testing is really important. And especially in those cases where there is already a case in that classroom, anybody who is experiencing symptoms should be extra cognizant of those symptoms and make sure to report them to their school health staff.
Thank you. And then Lexi or Indira, you probably remember this, but when was the state mask order lifted in 2021?
I don't have the exact date on me, but the actual answer to that is there is actually still a state mask order in effect, just for certain facilities. So it depends on which part of the order you're interested in.
I'm thinking like grocery store, just general public spaces.
Yeah, it was really an evolution because it went from everywhere all the time to like if a certain percentage are vaccinated, and those changes happened generally between April and May of 2021. It was very much a step down process, not a one day wear masks, one day we're out.
Yeah, and I mean, I just bring that up because when you look at the current wave of COVID, I mean, the COVID waves seem to kind of go for about 2 months. Then they drop off, then they can pick up again. And I mean, I know in April and May, it was probably the start of the Delta variant. And then obviously August, September, it was almost all Delta variant. And so when you look back, this wave is at as much or more than the April, May wave. And, we had mask order in place then in April and May. And yes, it was stepping down because the curve was coming down in May into June. And so, I mean, I just don't really, it makes sense to me, this wave, masks, last wave, masks. It's just, and we've had increased vaccination since then. So that's maybe even more troublesome that we still can't quite get that under control. So, I don't know if anybody else has any other questions or statements, please go ahead.
No, this is Lindy. I just wanted to say thanks for the information. It was a lot. So I'll want to digest more and likely may come back with additional questions. I was also hoping to receive the information that was discussed around the age group 2 to 5. I'd like to understand what the recommendations were coming out of the bodies that wrote those letters that we considered.
Hi, Elena here. Can you please specify, are you pertaining to mask wearing or the use of quarantine? Which policies in particular?
Sorry, thanks for the clarification. This would be for mask wearing.
So maybe the recommendations, Elena, from the American Academy of Pediatrics plus the local chapter of the American Academy of Pediatrics on why we did the cutoff at age 2.
Absolutely. So those agencies were very clear that masking is safe in ages 2 and up, and that individuals in that age can successfully wear masks, especially when being reinforced by adults who model that behavior. The American Academy for Pediatrics, including the Colorado branch that wrote the letter, and the CDC have urged 2 and up. They really didn't break down specifically 2 to 5-year-olds as being any different, really just looking at that population collectively as 2 and up, it's safe, and especially in the absence of vaccination for those age groups, just being absolutely critical to have masks, because we can't have the Delta variant, no vaccination, and no masks in this age group, and not expect to see substantial transmission.
One other piece of context that hasn't been mentioned yet for that age 2, there is a CDC federal order in place still that has been in place since January of this year for all public conveyances. If you've ridden on an airplane, you've probably heard them say masks are required 2 and up. That is federal law and the CDC's order. And so our order is also consistent with the CDC there. So a kid flying on an airplane who's 2 will have the same experience as a kid walking into a grocery store.
Okay, thanks for that. I appreciate it.
Yeah, and I just want to reiterate my appreciation for the deep dive on the childhood rates, the comparisons with mask and not. I mean, I do think it certainly reinforces my vote from August in terms of before school started, why this was an important public health order. I think looking at all of the data, right? You can look at CDPHE's data, you can look at School of Public Health modeling, who are the experts. I mean, you look at those names and they are the expert of expert in terms of how do you forecast COVID cases, extremely difficult. And their numbers have been pretty spot on. I mean, they predicted a little over 1,000 hospitalizations across the state by mid-October, and we didn't quite reach that. And right now we're at 944, I believe, as of today, and that hasn't, that's come down a little bit in the last week or so, which is good news. But it still drives home the fact for me that masking and transmission control, we're probably not social distancing as well as we were a year ago, but we're continuing to wear a mask, which will help with that, right? Help with that transmission control. And so, I see nothing, and I still see very troubling numbers in terms of hospital capacity. 25% of facilities are expecting ICU bed shortages in the next week. That's still a really troubling number. The data is all out there. And you got to look at a bunch of it. I get it. And I understand the concern with masks. My mask frustration is really high because I got hearing aids this year, and I've probably had 10 different times in the last week where the things flew off when I took out the ear mask. So, it's a pain. I get it, right? But it's the right thing to do based on the numbers that we're seeing. And, it will be over someday soon. Thank you.
Just to add to that, so this is an interesting time compared to last year, because we are really using just masking and then in schools quarantining. So it's a different situation where we don't have the social distancing, we don't have the restrictions on restaurants and bars and many of the other things that were still in place until early this year. And so I think it still remains to be seen how much we get out of masking. But this is, this is important for us to keep in mind that there are different factors at play in here, and trying to determine which factors are really what does the trick.
Yeah, I just want to share to your point that I have been looking at some of the recent literature, and it looks at the strength of all the different layered mitigation approaches. And it does say, the literature did suggest that masking is the most effective long-term strategy for preventing transmission as compared to what could be done with, capacity restrictions and the harms associated with some of these others that you just can't maintain over time. Whereas masking is one of the strongest layered mitigation strategies that you can maintain long-term. So I think that's a really good point, that of all the different layered mitigation strategies, this one is the one that seems to have the most ability to be durable long-term for a community without having too many impacts like capacity restrictions, social distancing, shutting down things.
Do we have another presentation on the universal mask mandate, or is this everything for the mask mandates? Can I bring up one thing then about the universal masking mandate? So it was mentioned that now as we come into winter, a lot of sports are going to move inside, and something that we may want to consider to make sure that people stay more active this year than they did last year is that a lot of these sports facilities have the air supported systems. So they have the bubbles, like the soccer field bubbles, the golf bubbles, the tennis bubbles. And we may want to consider looking into these and exempting them from the mask mandate because of the high rate of air exchange and the immense air volume in there. So I had found several engineering reports that all suggest for other cities and counties where they have exempted these as being basically equivalent to outdoors. And this might help maintain the activity of people in Boulder County while we're under a mask mandate. It's anecdotal, but what I have noticed is that gyms that don't have the vaccine verification, either people aren't going as much or they're not following the mask mandate. So offering these sports facilities as an option that's mask exempt might be something that we should consider including in the public health order.
Okay, I'm not seeing any other questions, so we still have an agenda item or two. Thank you again, staff, management, public. It's always good to, to really kind of hear the concerns and then use that interim period to really try and address them. And so, proud of you guys and keep up the good work. All right, we have item 5 on the agenda. We have to elect Board of Health officers. So most of you know, Lindy, I don't know if you do, but so when Jorge rotated off the board in August, he was the vice president. Are we doing the full suite of officers in this, or are we just looking for the vice president replacement?
This is for the full suite of officers.
Okay. So my past experience with this is that we can offer ourselves up, or we can have our peers nominate us, or so I've been Board of Health president 5 years. Time flies when you're having fun. And I will be termed out on the Board of Health in August of 23. So I've still got 2 more years. I am happy to continue in this role, but it is a a unique time. And so if anybody else would want to be president in anticipation of the future, I welcome that as well. And then I would, well, I won't nominate anybody yet.
How does the process work? So do we then call for a vote on the president and then move to the next?
We would probably call for if we have, let's say, one person for each position, we would then do the slate. You know, I suppose we could do it one at a time, but let's talk about, so we've got just president and vice president, right, Kate? Okay, so really all we need is a vice president. Yeah, I'm willing to be president. I'm willing to be just an average Joe. I'm willing to be anything, but you know, up to you guys in terms of, so the workload for president, just so you know that, you know, we correspond a little bit with the executive director in between the monthly meetings. I would say that's maybe an hour, maybe 2 hours during COVID times, but it's not much more than that. And then the president usually conducts the performance review or the annual evaluation for the executive director. So that's the big part of being president. Vice president really just fills in, chairs meetings when the president can't be there. And that's really about it. So we attend the board meetings regularly anyway. So vice president really, you know, as long as the president is willing to carry their load, then it's really not much of a difference at all.
Well, thanks, Greg, for your leadership and your continued willingness to be in a leadership position. And I would nominate you to continue to be in that role unless there's interest from somebody else on the board. And I will say I am interested in the vice president role, but I am also happy to give that to, if somebody else is interested in that too, I'm, you know, I'd love to hear about it.
No, I would also support Greg as president and Morgan as vice president. Morgan's been here the longest after Greg, so it just makes sense.
Yeah, this is Lindy. I agree. Since this is, I think, my 4th board meeting, I'll take everyone else's lead on leadership at this stage. So really appreciate that.
Okay. All right. Well, it sounds like we're in solid alignment. So if somebody, Brooke, if you would like to make a motion.
Sure. I make a motion that we approve Greg Thomas to continue in his role as president of the Board of Health, and that we newly appoint Morgan McMillan as the vice president of the Board of Health.
All in favor? Aye.
Aye.
Okay, it's unanimous. Thank you very much, everybody. Item 6 is director's report. It is about 8 o'clock. If there's anything burning on the director's report that you read, feel free to ask a question.
Nothing burning.
Me neither.
Very good.
Okay, and then item 7, old and new business. Before I move on, Camille, did you want to say anything about the director's report?
I did. I do want to point, thank you, President Thomas. I want to point the board to the portion of the director's report that talks about transitioning Board of Health meetings to hybrid and or in person eventually. And please do take a look at that. We are being very precise and considerate in all of the moving parts that must occur in order for us to move to a safe normal of returning to in-person meetings. And if you have any questions for me after this meeting, we can always chat. But we've laid out some very good options for us in the coming months to make that happen. It's just not as easy as flipping a switch. And so I wanted to bring that to your attention. And I know you've read the report, but it's something for your consideration. And we can have more discussion. But if you're concerned at all or have other ideas about our proposal, please do either speak up now quickly, because I know it's so late, or we can connect one-on-one as well.
I don't have any concerns with what I read, and I think a hybrid approach makes a lot of sense and seems to be the best practice or the norm right now. So, you know, we're clearly not out of this, and I mean, a hybrid approach does provide a nice option for the members of the public to weigh in, and that seems to be the biggest, you know, biggest advantage of what we've learned through this process over the course of the pandemic. So
that was our largest concern, President Thomas, is to ensure that those members of the public that want to participate but do not prefer being in person have that option. And it is just going to take us a bit to find the right venue and or to make the technology available in the spaces that we used to use there on Broadway Avenue. So we will keep the board informed, but we are moving in that direction. So thank you for your consideration.
okay. Okay, thank you, Camille. Item 7, old and new business. I don't have anything for the sake of time. All right, not hearing anything else. This meeting is adjourned at 8:01. Thank you, everybody, for staying on. I know these meetings have run a little longer than historically they have for good reason. And stay safe and enjoy the fall weather.
Thank you all.
Thank you.
Thank you, board.
Thanks so much, everyone.